Hello, everyone, and welcome to Cardiology Update viewers and listeners. My name is Shadi Reyes. I'm the Cath Lab Director at Detroit Medical Center in Detroit, Michigan, in the United States. And today I'm really interested and also, privileged to have one of the first author for a recently published paper in JACC Journal. The title of the article is Association of Beta Blocker Therapy with Cardiovascular Outcome in Patient with Stable Ischemic Heart Disease. This is a very interesting topic and very clinically relevant. And the teams kind of put it together in a way very helpful and clinically relevant. So with that, I would like to introduce the first author on this paper, Dr. Lucas Godet. He's from Peter Monk Cardiac Center in Toronto, Canada. Lucas, thanks for being with us.
Thank you so much for the invitation.
So let's start with Lucas with what is the rationale behind the study?
Yeah, sure. So beta blockers have been used for the treatment of patients with stable coronary artery disease for decades, really. And this is mostly to control their symptoms, to control angina. And there are a ton of data for patients with an acute myocardial infarction or for heart failure. The beta blockers are associated with cardiovascular risk reductions. They reduce the risk of having a new cardiovascular event in the future for these populations. But we really don't know if that's also true for patients with stable coronary artery disease. People will most oftentimes extrapolate the evidence from patients in the acute setting to the chronic setting, but we never really had a clinical trial, for example, really dedicated to this population in specific. So this is really what's the motivation for us to do this study.
Perfect. So in one line, what was the question of the study?
Well, the question was if beta blockers could be associated with cardiovascular risk reduction in patients with stable coronary artery disease.
Okay. So just to clarify to the audience, this is patients who have normal ejection fraction, but they have confirmed ischemic heart disease, correct?
Exactly. That's really the population. Patients without heart failure, without a recent myocardial infarction, and with documented stable coronary artery disease.
Great. So they are on guideline-directed medical therapy, angina medication and stuff, plus the beta blocker. So walk us through the design of the study.
Yeah, sure. So this is a retrospective study that we conducted using population of data from Ontario, Canada. So we're lucky to have data on the entire province. We have both administrative data and also a clinical data set with the clinical information that we were able to combine all these different data sources to create a data set for this study. We assembled this population really focusing on patients, as we said before, that had documented coronary artery disease, meaning patients in this study that underwent a coronary angiography and had significant coronary lesions, so at least 70% in one of the major territories. And also we excluded the patients with heart failure or a reduced ejection fraction and patients with a recent myocardial infarction in the last year. So essentially, this is the main population of the study. We also excluded some clinical comorbidities that could limit their survival to have a more homogeneous population. And once we had this cohort, we classified the patients according to their beta blocker prescription. So we were really interested in studying patients that were started on beta blocker at the time of the coronary angiography. And that's something that we call new users design. So everyone that was already receiving beta blockers for a long period of time before the coronary angiography was excluded from the study. And this is really to mimic what a clinical trial would do if we were to study the same question in a clinical trial. So usually someone that is already receiving the intervention of interest at the time of randomization in a clinical trial, for example, would be excluded. And that's what we try to mimic in this study. So we essentially classify the patients that were receiving beta blockers or not at the time of the coronary angiography. We have a 3-month time window to ascertain that. And then for the outcomes, our main outcome for this study was the composite of all-cause death, myocardial infarction, and heart failure, hospitalization for myocardial infarction and heart failure. And these patients were followed for approximately 5 years to capture these outcomes.
Right.
Since it's an observational study, we needed, of course, to account for confounders somehow. And the core methodology we use in this study is called inverse variability of treatment weighting, using the propensity score. So that's a way to balance the populations that were taking beta blockers or not and account for the confounders that we measured.
Interesting. Okay, so very, very robust database, a lot of patients, as you mentioned. It's retrospective study, but still has a lot of variables that you can adjust for to have a more clear outcome. So let's go over the main and primary outcome of the study.
Sure. So in this study, as I said, we follow patients for about 5.2 years in the median follow-up. And if we look at the numbers, after all those exclusion criteria, we had a population of about 12,000 patients that were receiving beta blockers and 15,000 patients that were not. So our primary endpoint, again, was a composite of all-cause death, myocardial infarction, and heart failure. And we noticed that beta blockers were associated with a small but still significant reduction in the in this composite. So the relative risk reduction was about 8%, hazard ratio of 0.92. And this translates to an absolute difference between the groups of minus 1.8% and a number needed to treat that we can calculate out of that of 56. So just to make clear, all these numbers are fully adjusted, even the absolute difference and the number needed to treat, they are all adjusted for all the confounders. And when we look at the components of the composite, death, MI, and heart failure, we observed that the bulk of this difference was really driven by reductions in hospitalization for myocardial infarction, with a hazard ratio of 0.87 for this particular outcome, a 13% reduction. And death and heart failure, there was not a significant reduction for these two outcomes.
Yeah, very interesting findings and a little bit surprising, don't you think?
Well, you mean the components of the primary endpoint?
Yeah.
Yeah, I think most people, including ourselves, if we were expecting to find a difference in this population, it would be very reasonable to find a difference in hospitalization for heart failure, given all that is known about beta blockers. We don't have at this moment a mechanistic, I'd say, explanation to understand better why beta blockers might reduce the risk of myocardial infarction if they are somehow interfering with the underlying atherosclerotic process, right?
Yeah.
Yeah, it's really it's interesting that they're reducing the composite and particularly the component of myocardial infarction hospitalization.
Well, one thing is I was expecting a more robust difference between the two groups in terms of patients who are receiving beta blocker, because as you know, beta blocker is a standard of care for ischemic heart disease, with or without stable or unstable. But I was expecting a bigger difference. But again, it's definitely the component of the primary outcome, as you said, the MI, hospitalization with MI as well as heart failure, is favoring beta blocker, but it wasn't kind of statistically significant, suggesting a signal, right?
Yes, exactly. They all trend in, let's say, the right direction, trends towards benefit, but really not statistically significant. And I just want to point out as well that these patients are all receiving standard of care really treatment. It's a contemporary cohort. So event rates in these patients of stable coronary artery disease, really the event rates currently are low, right? So to find benefit, cardiovascular risk reduction in this particular population, it's not that easy in the sense that their baseline event rates when they are well treated is already low.
Yeah, and just one question about the general population that you included. All of them were matched for the therapy that have been receiving in terms of other statin and other medication for blood pressure management?
Exactly. We did a weighting process that accounted for their medications as well, including statins, for example, that you mentioned. So yeah, this is taken into account when we calculate the propensity score. And then we give weights for people in the two arms so we can balance all those variables, including previous medication use for sure.
Perfect. So what is the future direction and how we can use this in clinical practice?
Yeah, no, that's a great question. Of course, this is a observational study, and as all observational studies, trying to infer causality here, a causal association between beta blockers and cardiovascular outcome. This is hypothesis generating, really. We cannot affirm or confirm with 100% of certainty that beta blockers are truly associated with the endpoint, because this, again, is an observational study. There might be unmeasured confounders that are still playing a role here that we're not able to measure and address and account for in our analysis. So this is always an issue, and really a clinical trial here would give us the definitive answer. That being said, I think this study demonstrates that there was no signal for harm in terms of cardiovascular events associated with beta blockers, and clinical guidelines at the moment, they don't recommend beta blockers specifically to reduce cardiovascular events in patients with stable coronary artery disease. They recommend for the control of angina. So clinicians might be more prone to keep their prescriptions of beta blockers in these patients, even if they have well-controlled symptoms, because there might be a benefit in cardiovascular event reduction as well. And again, of course, that to have this confirmed, we need a clinical trial in this particular population. The thing with clinical trials here, just to mention, of course, is that since the event rates are low, this would likely require a large population and a very extended follow-up. So it's also challenging to conduct a clinical trial to answer this particular question.
I agree with you. As you said, the guidelines is still not in full support for this cohort of patients, but definitely it's going to be very hard to do a clinical trial giving the low event rates, but you have a robust population. And I think it's your findings are significant enough to change, or at least to incorporate some of these findings in clinical practice.
Yeah, no, thank you for the comment. And yeah.
Thank you so much again, Lucas, for being with us. And as always, thank you, viewers and listeners, for Cardiology Update. Please follow the channel on Instagram, Twitter, as well as LinkedIn, and visit our website to get most up-to-date of news about cardiovascular news and cardiology, as well as interventional cardiology. Lucas, thanks for being with us, and congratulations for a new publication.
Thank you so much.